Yes, yes, you're visible. Yes, your voice is good. Go ahead.
At the outset, I would like to thank IMEMS and PN Rao sir for giving me this opportunity. So, any pregnant female who comes with 6 weeks of gestation and incidentally detected HBsAg positive status indicates that, for all practical purposes, is a chronic hepatitis B infection. And most of my slide and discussion will be about chronic hepatitis B in pregnant females. And it is common to get a patient in early pregnancy because the screening for hepatitis B surface antigen is mandatory as per WHO guidelines and NHM guidelines in the first prenatal visit itself. So why is it so significant to discuss the scenario of hepatitis B surface antigen positivity in pregnant females is because this pregnancy is a state of altered immune activity and it affects the natural history of hepatitis B. And there will be increased risk of hepatitis B infection flares during pregnancy. And pregnant females can have 6 to 14% chances of hepatitis B flares, and postnatally it can go up to 50%. But there is nothing to worry about this because most of these flares are mild and self-limiting and very rarely progress to hepatic decompensation and jaundice, and a lot of treatment options are available at present. And the other importance with respect to early pregnancy and hepatitis B positivity is the risk of perinatal transmission. And this is a special scenario because the safety of antivirals to be considered and cannot be generalized as other general population with a HBsAg positivity status. Had the patient presented to us prior to the conception, it is better if a woman of childbearing age with the advanced cirrhosis or fibrosis comes to us, we can offer therapy like pegylated interferon, which has a finite duration of period. However, in current days, pegylated interferon is rarely used because of availability of other effective antivirals. If a pregnant females with advanced fibrosis or cirrhosis presents to us, if she's a newly diagnosed chronic hepatitis B with presence of fibrosis or cirrhosis, out of the available multiple nucleoside analogs, the tenofovir disoproxil fumarate has proven to be safer in pregnancy. And if the female is already on antivirals, we have to switch her to any other nucleoside analog therapy to a TDF-based regimen. If a pregnant female comes without any advanced fibrosis or cirrhosis, antiviral prophylaxis is indicated if she has a high viral load. For this, we have to test her hepatitis B DNA levels, quantitative analysis, and HBsAg levels. If DNA levels are more than 2 lakhs international unit per ml or HBsAg levels of more than 4 log, it warrants antiviral therapy. So now the question is when to start an antiviral therapy. Antiviral prophylaxis should start by 24 to 28 weeks of gestation because it allows sufficient period for the viral load to come down prior to the delivery. And what medication to start? Out of the available nucleoside analogs, only 2 medications have been proven to be having safety data in pregnant females, that is tenofovir disoproxil fumarate, that is TDF, which is commonly given at a dose of 300 milligram per day, and telbuudin. Out of these two, TDF is a preferred drug of choice currently. And when to stop antivirals in these patients? So the stopping of antivirals varies according to different guidelines. EASL, that is European Association for Study of Liver, suggests to stop treatment after 3 months following the termination of pregnancy. And as AASLD supports stoppage of medication after 1 month of termination of pregnancy. This is the summary of my slides. If in the first pregnant antenatal visit,
Recording in progress.
If a patient is HBs negative and anti-HBs antibody is negative, that means the patient is not infected and not immune to hepatitis B infection, and these are high risk to acquire new infection, and we have to vaccinate all these individuals. And vaccinations for hepatitis B are safer during pregnancy, and they can receive the complete course of vaccination. If a patient is hepatitis B surface antigen positive, if she has active disease or cirrhosis, consider to start treatment immediately, preferably with TDF, and test all the household contacts and her sexual partners. And if HBS is positive, if there is no advanced liver disease or cirrhosis, test HBV DNA immediately and at 24 to 28 weeks of gestation. If DNA is more than 2 lakh international unit per ml, consider treatment, and stoppage of therapy can be done after 3 months of delivery. And if the DNA levels are less than 2 lakh international unit per ml, no antiviral therapy is needed. However, the infant receives full dose of vaccine to be started 12 hours after before 12 within 12 hours of the delivery, and hepatitis B immunoglobulin at birth. And all these pregnant females should be monitored postpartum for the flare of hepatitis B infection, with frequent monitoring of alanine aminotransferase and HBV DNA levels at 1, 3, and 6 months after the termination of pregnancy. To prevent mother to child transmission, C-section is not universally indicated, and it can be considered only in HBeAg positive women with a very high DNA titers of more than 7 log copies per ml, who have not received antiviral therapies during pregnancy. And hepatitis B immunoglobulin and full course of hepatitis B vaccination should be administered to the newborn within 12 hours after the delivery. This prophylaxis can reduce the rate of perinatal transmission from over 90% to less than 30%. HBeAg and vaccine full course can even can fail and can result in the perinatal transmission, and this scenario is almost exclusively seen in HBeAg positive women with a very high DNA levels and or surface antigen levels of above 4 to 4.5 log per international unit per ml. Coming to the next course, whether the breastfeeding is allowed or not in these population, there is limited data available for most of the antiviral safety. However, tenofovir disoproxil fumarate is found to be excreted in negligible quantities in the breast milk, and oral bioavailability in the neonates is lesser. So there is no contraindication for breastfeeding in hepatitis B infection on or without the antiviral therapy. However, mothers with detectable HBV DNA levels with cracked nipples or infant who has oral ulcers, it is better to feed with caution, or feeding be better avoided until the healing of the wounds. If not, the breastfeeding is not contraindicated in chronic hepatitis B. With this, I would like to